Welcome to the Motivational Midwife. I'm Lynn Jones, and today we're going to look at shoulder dystocia. So let's look at shoulder dystocia, and as always we'll start with the definition. So in simple terms, really a shoulder dystocia is where those shoulders have got stuck. They failed to deliver with the next contraction and some gentle axial traction. So you need to step in and do some additional manoeuvres to help release the shoulders. And how are you going to recognise it? Well, if you've got somebody who's pushing and the head is coming, but it's taking really a long time for that face to actually deliver, that should alert you to the fact that you might have a problem with the shoulders. And then when the head has delivered, it's almost instantly sucked back against the perineum. So what you essentially get is this very squashed face right back up against the perineum. And that's called turtleneck sign. There's usually a lack of restitution as well. That baby hasn't either fully restituted or hasn't restituted at all. And gentle axial traction, as we've said, has failed. And so axial traction is that sort of straight in line with the spine traction, not downward traction at all. And RCOG have suggested that since about 2012, when they released this guidance, that all deliveries really should be facilitated with axial traction to prevent that excessive traction on the brachial plexus. And certainly when I trained, we were taught downward traction, but the key word is gentle downward traction, not excessive downward traction. And often you will need to use a bit of downward traction, particularly if somebody is on a bed, sitting on a bed, because their coccyx can't move freely as it can if they're in the more upright positions, all fours, left lateral, those things. So often it does need a little bit of help around the corner. So how often does this happen? So about 0.5% of births, so about 1 in 200, will be complicated by shoulder dystocia. And in the last Perinatal Confidential Enquiry to be published in 2017, 4 babies actually died as a result of complications from shoulder dystocia. It is a hypoxic event for this baby. The cord pH will rapidly reduce, so you really haven't got very many minutes to manage this emergency before your baby's pH levels are at a point where they are going to cause some serious damage. So what risk factors are we looking at? So alarmingly, almost 50%, there are no risk factors, and the baby is a normal birth weight baby as well. So really you should have in the back of your mind for most births that shoulder dystocia is always a possibility, but don't let it cloud your management, but you just have it there, sitting there as it's a possibility, and look out for those key signs that we've said of how you would recognise it. Like with all emergencies, if she's had one before, she is likely to have another one, depending on what the reason was she had that shoulder dystocia. Diabetes, particularly uncontrolled diabetes, often leads to very macrosomic babies, so there's really big babies. And obviously if you've got a really big baby, there is the risk that the shoulders may have difficulty in birthing. And postdates for the same reasons, the baby's likely to be a bit bigger. Maternal increased BMI, particularly over 30, 35, again, they may well have big babies on board. They may also be more predisposed to gestational diabetes. If you've had a very long first or second stage, you should be asking yourself, why is that happening? And those long first or second stages often lead to augmentation and instrumental delivery. So you do need to think to yourself, why has this baby just not birthed itself? Secondary arrest is where they've been contracting really well and then the contractions just stop for no apparent reason, and obviously that often leads to augmentation. Then you do need to have at the back of your mind, why has this happened? Is there a logical reason for why that has happened? And induction of labour, because it does very often lead to augmentation and instrumental deliveries. So it is important that we use a very systematic approach when we are dealing with shoulder dystocia. Okay, time is of the essence, as it is with all of the emergencies, but particularly with this one, because we've said that pH can drop very rapidly. So the RCOG divides the management up into first line manoeuvres, second line manoeuvres and third line manoeuvres. And very often a lot of places use a mnemonic helper, HELPERR, to help remind you of the order of things, but a lot of places don't either. Really, the key thing is being systematic. So as with all emergencies, the first thing you need, in this presentation I've used helper as well, just for those of you that are familiar with it, so that you don't get too confused. So the H is for help. You need help. You cannot do this on your own. So pull your emergency bell, get some other people into the room. You want some other midwives to help you, because you can't do all of the manoeuvres on your own. And certainly if we get to second line manoeuvres, those internal manoeuvres, you really need your obstetricians there. So your senior obstetricians, your registrar and consultant, because if you can't release those shoulders, there is a good chance that they're going to have to do then third line manoeuvres when we might need our anaesthetist. We almost certainly will need a paediatrician. This baby is going to need some resuscitation, quite likely, depending on how quickly you can get those shoulders birthed. And above all else, explain what's happening to the mother. Okay, try and keep a calm approach, because you need her cooperation, and the calmer and more coherent you are and how good your communication is with her, then she is more likely to cooperate with you. And you need someone to scribe for you, so delegate someone to scribe who's in the room, what they're doing, any manoeuvres that are used, the timing of events, and then you will obviously transcribe those after the event, adding some rationale as to why things were done the way they were done. So the first thing, stop her pushing. This is a bone-on-bone impactation. Okay, so if she is this this shoulder, okay, it's more commonly the anterior shoulder has got stuck on the symphysis pubis. Less commonly, the posterior has got stuck on the sacral promontory. So the most common thing is that the anterior shoulder has got stuck on that symphysis pubis. It's not coming anywhere. So if she's just pushing, you're just going to further impact that shoulder on the symphysis pubis. So get her to stop pushing. Give her the Entinox back if she hasn't had it already. Lay the bed flat. Make sure she's got a pillow under her head, but get her to move to the end of the bed, or if you're on a delivery bed, take the end of the bed off. This really just gives you a bit more space to get in there. Okay, then we move to our L. Our legs, okay, and a manoeuvre that you've probably heard of is McRoberts, and this really is an exaggerated knee, chest, abducted thighs, and this is not a particularly flattering picture of myself, but it does show you that those legs really do need to be brought up as far as they possibly can towards the mother's chest. Okay, so you need them abducted slightly so they're out slightly and pulled right back against her chest. Now I'm holding my own legs in this picture, but really in reality you've usually got a midwife either side doing this. If she is already in lithotomy position, so that's where her legs are already up in the stirrups, then it is important that they are taken down, straightened and then put back into McRoberts, because if you don't do that, you're not going to get the changes that doing McRoberts does. And it does three things. So the first thing it does is it changes the angle of inclination of the pelvis, so it widens that AP diameter, so makes a bit more room. Secondly, it flattens this sacral promontory here, this bit, it flattens it out a bit, so again makes a bit more room. And the third thing it does is it helps with the lateral flexion of the baby. So that sort of flexion like that, it helps with that. And if you think back to your mechanisms of normal birth, the baby is usually born by lateral flexion, isn't it? It flexes its way around. So those three things happen when you do McRoberts. So that pelvis tilts, flattens the sacral promontory, makes a bit more room, that AP diameter is widened, and that can sometimes just be enough to help you birth the baby with some gentle axial traction. So although RCOG quotes this as 90% success rate, actually figures vary quite widely. So some places only really quote it as a 70% success rate, but it does have a high success rate. Certainly the vast majority of shoulder dystocias that I've been involved with have resolved with McRoberts, plus or minus the next manoeuvre that we do, suprapubic pressure. So it is a very useful one to note. What happens in some places is people will use McRoberts prophylactically, so they'll use it in anticipation of a shoulder dystocia. And really, I have mixed feelings on that, because you wouldn't know if that lady then had a shoulder dystocia and it was just resolved because you had her in McRoberts, or whether she never had one in the first place. And you need to think quite carefully, because it does affect future birth options. So, think carefully about using McRoberts prophylactically. So moving on to our P is suprapubic pressure. Okay, so you need to know where the fetal back is, because what you are trying to do is apply pressure on the fetal back to try and rotate it. Okay, so you're putting pressure on the anterior, so the top, the back of the top shoulder is where you are putting pressure. And usually you would adopt a CPR grip, so a grip like this, and this part of your hand would go just above here, just above the pubic, because if you're pushing on the pubic bone, you're not going to get anything. So you need to be just above the pubic bone, so supra, above the pubic bone. And that's where you're going to apply some pressure. And years ago, we were taught, 30 seconds of rocking and then 30 seconds of just force pushing. There really isn't any good evidence to suggest one is better than the other. So just do it. And really, you're doing suprapubic pressure. She's in McRoberts. The delivering midwife is going to try some gentle axial traction. If that fails, you move on to your next maneuver. Okay, so we're moving into the realms of second line maneuvers, so our enter maneuvers. So at this point, you need to evaluate the need for an episiotomy. And what you need to remember here is an episiotomy is not going to solve the problem. The only thing an episiotomy will do is give you a bit more room to get your hand in. And that's assuming you can actually do one. Remember, this head is very, very tight against the perineum. It is extraordinarily difficult to get in to do an episiotomy. And certainly I've never seen anybody successful in doing an episiotomy when that head's so tight against the perineum. Okay, it's a bone-on-bone impactation, so an episiotomy is only soft tissue. It's going to give you a bit more room, not going to resolve the shoulder dystocia. So then we are moving on to our second line maneuvers, and you as a clinician are trained to do these. Okay, you will get them in your training, and what you do, many years ago, they were quite prescriptive in how you had to do things. When I trained originally many years ago, and we did this, you had to do them all in a specific order. Now that is no longer the case. Okay, you use what's called a Pringle grip. Okay, and this grip, because this is the grip you would use to get the last Pringle out of the Pringle packet. If you try and go in like that, you'll not reach the bottom. So it's the same. You're making your hand as small as you possibly can, and you are going in posteriorly. Okay, so she is you go in at the bottom towards her the posterior vagina. So you might have to lift the baby's head up a little bit to try and get in there. So you go in posteriorly and you get as much of your hand and wrist in as you possibly can. And once you're inside, you determine whether you can remove the posterior arm or whether you need to turn the baby into a oblique diameter. So the oblique diameter is slightly wider, so you need to determine whether you can shift that baby into a oblique, let me put it this way. So you're either trying to remove the arm or you're trying to turn the baby this way or that way to make it easier to try and deliver. Okay, and that is entirely down to you. So in order to deliver or remove the arm, what you need to do when your arm is in there, and I'll see if I can try and do it this way so you can see, is you have your arm in and you're going to slide your fingers down until you can reach the elbow. Now, if you can apply some pressure in the antecubital fossa, so the elbow bit, and that will usually make the baby's hand flick up. If you're really lucky, when you go in, the hand is just sitting there, and then you can grab the wrist and bring the baby's hand out. Now, what that will do is once this posterior arm is out, so posterior will be that way, once it's out, this anterior shoulder will drop, and so it will come under that symphysis pubis, and then you should be able to deliver the baby because that diameter has been reduced, so it can come out. Okay, if not, you're going to have to try and put your fingers right up either to the top, okay, so the back of the top shoulder, and push the baby that way, or you might be at the bottom and push the baby that way. Okay, if you can get another two fingers in the front, you may be able to do a twisting motion, but it is very tight and very difficult to actually get two fingers on. I have put a link in the comment section below to a video on YouTube from Prompt, who actually demonstrate and explain this really, why this baby's head gets stuck really very well. Okay, if that fails, then you need to roll her over. Okay, so you put her over on her knees and then repeat your enter maneuvers. And the reason that that sometimes is helpful is the fact that you have rolled her over. A, you've got a bit more room to get in. Remember, you're still going in here posteriorly. You've got a bit more room to get in, but sometimes the process of rolling over also dislodges the shoulder. If you have a lady with an epidural that's, you know, she hasn't got a lot of movement, then that's not going to be particularly easy to do, and may not be practical at all when you think time is on your not on your side here. But if you've got a lady who is slim, is very mobile, then actually you can get her over on all fours fairly quickly. If she is in all fours already, then please don't turn her back onto her back to do your McRoberts. Go straight for an enter maneuver, or you could get her to come right back on her heels, because that essentially is an upside down McRoberts, and see if that frees the baby's shoulder. If not, go straight for your enter maneuvers and try and release that arm. And then if that fails, turn her over onto her back and repeat the McRoberts and suprapubic pressure. You can't do suprapubic pressure in all fours, you just can't get under there. If they all fail, then you are looking at third line maneuvers. Now, to be fair, I've 2 out of 3 of these I've never seen, and they don't happen all that often in this country. But the first one, clidotomy, whereas they fracture the baby's clavicle, and you might think, oh my goodness, that sounds awful, but actually it breaks very easily and just snaps between 2 fingers quite easily. And why will that work? Well, if you fracture the clavicle, what will happen is that the shoulder will come in, so you have reduced that diameter. Okay, so your diameter from here to here, you've reduced it, and so that making that smaller should make it easier for the baby to birth. And symphysiotomy, this is where they actually slice through this ligament that is here, that is holding the pelvis together, and so that pelvis essentially just falls apart, and obviously that will then free the shoulder. However, it's not great postnatally for these women. They need to have this bound up and have quite a lot of morbidity postnatally from these, but it does happen quite a bit in third world countries, I believe, but not so much here. Zavanelli is where they rebirth the head. So the head is out, it's well stuck. They have to reverse. It's not just a case of shoving it back in. You have to, the whole mechanism of where the baby has come down and rotated, you have to reverse that and push it back up and then do an emergency cesarean section. Now, in this country, this is not something that we do a lot, and so therefore the skill required to do it really is lacking, and so we don't have very good outcomes if we were going to this. In countries like America, where they resort to this very rapidly, they have a lot more skill at those sort of things, but they don't tend to do the other things, which surprises me. Your baby, when it arrives, is going to require some resuscitation. Okay, so if it's birthed after McRoberts, it may require just primary resuscitation and not very much help at all. But what you will need to do is ensure that the paediatrician has actually given that baby a very thorough examination to exclude any birth injuries. And it is useful to take some cord gases just to see how compromised that baby has been. So this algorithm is very useful. This is the RCOG algorithm, which just really reminds you of the systematic order of when to do things. And some of the consequences then, well, for the baby, there's our 5 H's of resuscitation, which, as I say, we'll go into when we do the newborn life support. We'll do it in a little bit more detail, but you've got your hypoxia, hypoglycemia, need to hydrate that baby, the delay in going home, and hypothermia. Fractures are very common in babies with shoulder dystocias, either fractured clavicle, fractured humerus when we're delivering that arm, brachial plexus injury, so that's that Erb's palsy. So we have this waiter's tip hand, so the baby's hand arm hangs down and the hand tends to be sort of tipped behind, and that is generally as a result of excessive traction on this brachial plexus. Hypoxic brain injury, so HIE, as we've said before, any degree of hypoxic brain injury, if we haven't managed to facilitate that birth ideally, the head to birth interval should be less than 5 minutes to really minimise the risks of HIE. This baby, if it is really quite compromised, will need admission to your special care baby unit, your NICU unit, and it will then be at risk of all the complications of a NICU admission. Unfortunately, as we've seen from that MBRRACE report, that some babies do die. So although we manage it reasonably well, they do die. If they are in NICU, then obviously they're going to be separated from the mother. So you need to think about how you can facilitate visiting, bonding with that baby. And so thinking of some of the consequences for mother, obviously you've had your hands inside her vagina. So there is likely to be quite a bit of soft tissue trauma. So vaginal tears, perineal tears, 3rd and 4th degree tears, not uncommon, bruising, not uncommon. She is at increased risk of infection because we have done all these internal manoeuvres, so she will need some prophylactic antibiotics. Again, she's at increased risk of postpartum hemorrhage because we've done all these internal manoeuvres. Sometimes you do get a spontaneous symphyseal separation, so that little bit of ligament separates on its own. I've never seen it, but it is documented as happening, as being a potential consequence. Again, if the baby is in special care, think about how you're going to facilitate bonding, how you're going to facilitate feeding. Do you need to get her expressing? you could be dealing with a mother who has lost the baby has died, or certainly she'll be grieving if the baby is damaged in any way. She'll be grieving potentially for the baby she was expecting, but hasn't got, because it hasn't come out a nice pink screaming baby. Potentially there is a risk of a uterus rupturing. If she has had to have Zavanelli manoeuvre, then obviously the caesarean section with all of those associated risks. And this can be quite a traumatic event for parents. So careful debriefing for both the parents is really key. You need to give them opportunity to talk through the birth, what happened, why things were done the way they were done, and give her an opportunity to come back and discuss that again. And she may well need more than just our debriefing, so you may need to consider referring her for some proper counselling, because as midwives we are not trained counsellors, and so it's important that we refer to the appropriate people. And there we have it, a whistle-stop tour of shoulder dystocia. I hope you found it useful. If you haven't subscribed to the channel already, please do so, and encourage your friends to subscribe to the channel, and I look forward to seeing you next time.